our 3-day masterclass titled Healthcare Facility Design, What We Can Learn from COVID-19. This is being done in partnership between the AAK and the PharmAccess Foundation, which is an organization with a mission to make better healthcare accessible and affordable to all Kenyans. So just before we begin, I'd like to just give a few housekeeping rules. We'd like to see your video. We'd like to see your video on. Make sure you're muted unless you're speaking. If you'd like to speak, just raise up your hand on the tab down below and we'll be able to let you unmute. We have presentations after which we'll have a Q&A session where you can also give your questions. But in between the presentations, you can also make use of the Q&A tab or put your comments in the comment section. So without further ado, allow me to introduce to you our chair of the Architects chapter, Architect Arabu, to give us opening remarks. Thank you.
Thank you, Brenda. I hope I'm audible enough. Good morning to everyone from wherever you are joining. And apologies for those who are joining us from further west, I think Nigeria and Ghana. I think we woke you up too early. And also just to say that, acknowledge the fact that this session is attended by various parties. Of course, most important are our members from across the globe. We also have our main partner, PharmAccess, attendance from Nairobi and also from the Netherlands. We also have, of course, our secretariat and the people who are working behind the scenes. So in as far as this event is concerned, we are trying to work within the vision of the 35th Council of the Architects chapter to bring and create opportunities for our members, as well as promote education and training. So as a matter of a nicely rounded up event, this particular one event captures both visions very clearly. I'm going to invite two representatives. One is, of course, our very president, Wilson Mugambi, who will, I will ask him to give us a welcoming remark because he's really the main host of this event. And I'll also welcome later on Dorian Muller from PharmAccess to give remarks. So without any further ado, President Wilson Mugambi, please go ahead.
Fellow professionals, partners, colleagues, ladies and gentlemen, good morning. I would like to say that I'm very pleased to have you here. I am not the host, the AAK is actually the host, but thank you, Arabu, for giving me that extra sort of platform to have bragging rights later on. This is a very called for sort of engagement because as AAK, we have always felt that we need to give and arm our members with the kind of skills and knowledge that will help them add value, not only to their practice, but also to the industry at large. What has COVID-19 taught us? COVID-19 has taught us that we can never be ready. We can never be so sure about what to do. But at the back of it, I think one of the lessons that we've learned is we need to have a very dynamic approach to all kinds of eventualities. And of course, the world has not seen such a pandemic for quite a number of decades. And it has really reset how we think, how we work, how we live, even how we enjoy our free time. So it's you're no longer able to go to a restaurant, you're no longer able to go to a bar the way you would normally do. And you can imagine the hardest hit places are the hospitals, the core of healthcare. And we as professionals, we should be at the forefront of coming up with solutions of how to deal with such situations. So I would like to appreciate our partners in this case, PharmAccess Foundation, Healthcare Insurance Fund, Medical Credit Fund, Safe Care, Healthcare and Standards, who have come and have given us the kind of support we need, such that we'll be able to extend this knowledge and arm our members with the know-how of how to approach this kind of epidemics. But on the flip side, it's not just about epidemics. I think it's about how we're able to think on our feet. How ready are we? And over the next 3 days, we're going to be getting a lot of insights on the Kenyan context, South African context, and even context from the United States and Europe. And the whole point is to give us a view of the challenges that we face as a country, are not specific to Kenya alone, they're actually global. And with that, I would like to say asanteni sana for attending, for the partners who partnered with us. And let us look forward to a very engaging and a very insightful 3 days. Asanteni sana and enjoy.
And just as a matter of clarifications, the videos you saw earlier, that is not present day, it was the old good times pre-corona. Corona. So don't be surprised that there are no masks. And also let me acknowledge the fact that we have the day one power presenters here whose CV will be read in very brief, but very powerful with very long CVs. So now let me take this opportunity to invite Dorian Muller, who will to speak, give opening remarks on behalf of PharmAccess. Dorian.
Thank you. Thank you very much. I will keep it brief. As was mentioned, PharmAccess is aimed at improving access to better care in Africa, including Kenya. And while I'm working at the Medical Credit Fund financing hospitals and also financing construction in hospitals, we realized that we need architects to have knowledge about how to design hospitals if we want to improve care. And that we realize especially during COVID, as the future of healthcare in Africa rests for a large part also in your hands as architects to design hospitals that can cater to epidemics like this. We would like to thank AAK for the opportunity for this partnership, but also CDC Group, which is one of our investors, for supporting the speakers to give these speeches. And I hope you enjoy the next 3 days, starting today with, I think, everything you always wanted to ask about COVID-19. You can shoot at the experts that will be presenting today. Thank you. Brenda, up to you, I think.
All right, thank you so much, Dorian. So allow me to introduce to you the speakers for today. I promised them that I'll just highlight a brief statement about their bio, but I'll start with Professor Tobias Rinke de Wit. Professor Tobias is a molecular biologist and public health specialist. He comes from PharmAccess, Netherlands. He's also a director of research at the PharmAccess Group and Job Lunch Institute. Tobias serves as the chair of the WHO Global HIV Drug and Resistance Network Advocacy Group and has also worked on COVID-19 in Africa, in particular digital mobile rapid diagnostics. That's just a highlight of what it is that he has done. I'll also introduce our second speaker for today, who is Dr. Simon Onsongo. Dr. Simon is a medical doctor with a background in clinical pathology, currently based in Kenya. He's a graduate of the University of Nairobi, class of 2007, and Aga Khan University, 2013. He has also had further training in the University of North Carolina and also Royal Adelaide Hospital, 2017. So Dr. Onsongo is a member of the BioRad Global EQAS Task Force and is currently the Chancellor of Kenya and the rest of Sub-Saharan Africa at the International Society for Laboratory Hematology. So those are our two speakers. I think now we'll start with a presentation from Professor Tobias de Wit. Welcome, Professor.
Thank you very much, Brenda, for this excellent resume. And good morning, everybody. Can you hear me? I think so. Very good. It's a pleasure to be here. And I'm a biologist. I'm not a medical doctor like Dr. Simon is. And I think, you know, what I learned this morning already is that architects are people who apparently have to design buildings also with a view on their lifespan and on their death. It is a whole process, and in a way nature is the same. It designs by mutation and selection. You continuously mutate, you design new buildings, and then some of them survive better than others, and that's survival of the fittest. And maybe that's a law that counts in architecture as well as in biology. So I like the statement by Wilson of a dynamic approach to eventualities. Well, COVID-19 certainly is an eventuality. So I'm going to give you some highlights on COVID. Please feel free to put your questions in the chat box if you like. And Brenda, you can interrupt me as soon as the questions explode. Okay, here we go. First of all, COVID, there is so much to say about it, and there's so much facts, but there's also so much fiction. Fake news, all kinds of strange things that are coming up. And basically, I'm trying to avoid that, and I'm trying to stick to the science. And even that is extremely difficult because every day there are 300 articles published about COVID. Well, nobody has the time to read them all. It's impossible. So we form groups of specialists who keep each other informed, and I'm in such a network. So I hope I can update you with the latest remarkable findings on the virus. But it is a huge challenge. First of all, epidemics. And where do epidemics come from? And pandemics come from, it's basically eventually human behavior. We are scavenging the earth. We are cutting down trees in forests. We're traveling all over the place in airplanes. We're eating in different places of the world, wild meat of wild animals. We have a habit of crowding together in huge crowds. Well, you can imagine that these are ideal circumstances for viruses that live in forests with wild animals to jump to human beings and to spread all over the world. And that's exactly what happened also with COVID again. What we do see is if we compare the 21st century with the 20th century, that there is a large number of outbreaks. It looks like epidemic outbreaks are accelerating. We had in the 21st century already the first SARS epidemic, which is also coronavirus. We had MERS in 2012, also coronavirus. Here, of course, is SARS-CoV-2, which is the current epidemic. We had a huge influenza epidemic earlier. We had chikungunya, we had Zika, we had dengue, we had Ebola. It goes on and on and on, and it's accelerating. In other words, this is a warning sign for human behavior, and for our next generations, we should, from a biological point of view, take this very much into consideration. If we talk about COVID, it clearly started somewhere around markets in Wuhan, in China. It is not completely clear where it really started, on the market or around those markets in an action radius of a couple of hundred of kilometers maybe of meats that was brought to the market, or that's still unclear, but it is very clear that it started in China. And from China, it went all over the world. And here we can see different transmissions of the virus early in the year 2020 in January, where it went to Europe and where it went to the United States. And the viruses that entered the United States, they entered in the west coast of the United States, in Seattle, in Washington State, and also in California. And you can see also that there were different introductions of the virus. And in dotted lines, these were introductions that failed. And in straight lines, these are introductions that did work out. And for Europe and for Africa, the most important one is this one, the one that went to Italy from China. There is a huge connection there between China and Italy. And that's where the outbreak in Europe started. And the European viruses are the key viruses that went to Africa later on. If we look at the top 10 epidemics in the world, as far as we know, mankind, then COVID is at the moment at position number 9, with approximately 3 million people who died of the infection, as far as we know. For example, HIV/AIDS is in position number 4, just to give you a bit of an idea. And the number 1 of all times is the Black Death, that, as far as we know, took place in Europe in the 14th century, and which killed almost half of the European population. Approximately, one estimates between 75 and 200 million people. That was a huge one. The second one, by the way, was the Spanish flu that took place just after the First World War in Europe, and that killed more people than the First and the Second World War together. And so, epidemics have been there for thousands of years. Outbreaks take place, and they can be very, very, killing. One of the things that is very interesting is if you do all kinds of tactical analyses and so on, then then you can find certain epidemics that come up in the past. I'm not going to go to the details here, but basically I wanted to show you this one. One of the other top 10 epidemics was the Russian flu, and that that happened in the year 1889, and it took 4 years to continue. And it's indeed started in Russia. And why did it start there? Because railroads were being built. And we see here also that architecture in a way plays a role. In this case, railroads and buildings and spreading of people all over the planet. And there was increased traffic between Russia and China and Europe. And this virus originally came from rodents and then into cows and then to humans. And in fact, it was a coronavirus also. It was the coronavirus OC43. Forget about the name, but it was one of those really killing viruses. It killed 1 million people out of the 1.5 billion people who then lived on the world. So it is proportionally even a bigger epidemic than the coronavirus of today. It just shows you that corona outbreaks are happening. They also happened 100 years ago, and they will happen in the future. Also, it's important to know that coronaviruses are all over the place, and I'll show you more about that, talking about the virus. Well, how does it look like? Here, it also shows you here schematically the spike protein, which is making the corona, the crown of the virus, the yellow proteins here, which are sticking out of the virus. These spike proteins are used by the coronavirus to stick to the host cells of the human beings and of their hosts in nature. And then there is genetic material inside the virus, which is called nucleic acids, and there are some limited proteins. It is a relatively simple organism, although if you look a little bit more in detail, and we're not going to study that, of course, but here you can see all the genes, it still is quite complex. It has something like 25 to 30 different genes. It's one of the more complex viruses. For example, compared to HIV, it is 3 times bigger and it has 3 times more genetic material and genes at its disposal. And how does it live? People always ask, does a virus live or not? Because a virus cannot replicate itself. It cannot build itself. It needs architects to become constructed. And in this case, the architect is the human cell, here in blue. So the virus enters the human cell through a so-called receptor. The receptor is called ACE2. Forget about it. Here's the virus. It uses the receptor. It enters the cell. It spits out its genetic material into the cell. And then it hijacks the mechanism of the cell to replicate this genetic material into new viruses that subsequently leave the cell again for the next infection. So it is basically, the virus is completely dependent on the architecture of the human cell or of the host cell in general. And yeah, in a way you could say, well, the virus doesn't live by itself. It needs somebody else. On the other hand, I would say, well, an organism that can create so much havoc in the world definitely lives. What about zoonoses? The viruses, where do they come from? Well, there are in fact already 7 coronaviruses described for human beings. 4 of them, you saw one of them are older viruses, and 3 of them are new, of the 21st century. And the difference is that the older viruses, like the OC43, which I showed to you, the Russian flu, they are less dangerous. Why? Because we're used to them. And we have lived with them for 100 years or even 200 or 300 years, and they give just a normal flu, a dripping nose, children's diseases, nothing special. The new viruses, however, which are just recently jumping to human beings, can give very severe disease because we're not used to them yet. Our immune systems don't know them yet, and we get very sick and we get sometimes hospitalized. And particularly, of course, in the West, we've seen that a lot. So in a way, corona will accommodate to human beings. In 100 years from now, I can assure you that coronaviruses and also COVID-19 still will be around somehow, but just as a normal flu that doesn't cause anything special. The thing, of course, is that we don't want to wait for 100 years. And we would like to get rid of this virus quickly. Where do those viruses come from? Most of them from bats. Bats are carriers of viruses, and I'll come to that in a second. And then bats can infect other animals, interim hosts, and those can infect human beings. So, for example, MERS, came through camels into human beings. Bats were infecting camels, and the Middle East respiratory coronaviruses infect human beings. Coronaviruses went into civet cats, the SARS-1 epidemic, and then in human beings. At the moment, of course, the virus is in human beings, they can infect each other, infect people in the hospital, and then, yeah, a transmission has taken place. And we call that a zoonosis, a virus that comes from zoos, from animals, into humans. And that is always very dangerous. If a virus jumps from one species to the other, then the new species has to get used to the virus and usually gets pretty sick. What do we know about COVID-19? Probably it came from the pangolin, which is a well-known animal also in China. It is eaten, you can buy it on the markets, and it's very likely it came from a bat into a pangolin, into a human being in China to start with. What about bats? How can we stop this from happening for the future? Well, the problem here is we can't. Bats are basically everywhere in the world. Here we see just an overview. There are at least already 30 different coronaviruses described who are in all those different types of bats. And bats are flying around hundreds of kilometers. They are the airplanes of the mammal kingdom. They are highly diversified. There are 1,400 different types of bats in the world out of the 6,400 mammals. So 1 in 5 mammals is a bat. Forget about trying to get rid of them, trying to kill them. There's no way we can do that. And so coronaviruses, which are in bats, will be with us as long as bats are with us. And that means that outbreaks can happen anytime again in any place with a new coronavirus, also in the future. And then mutants, you've heard about that. Coronaviruses, they can mutate and they change into sometimes more dangerous viruses. Here we see a very good example in Europe from January to May of the orange and blue viruses. In the beginning, the orange virus was predominant, and then it mutated into the blue virus, and that took over completely in Europe. And here we see the difference between the blue and the orange virus. The blue virus has one single mutation, which makes it replicate much faster. Therefore, it gets more offspring, and therefore it is more infectious and more successful. So automatically, it overcomes by mutation and by selection. It overcomes the orange virus, and Europe was repopulated with the blue virus in the early phases of the year 2020. This is just one example of mutations, but in fact, there are thousands of mutations in coronaviruses. And the thing is also, it's not only the virus that mutates, it's also the receptor that mutates. So the binding of the virus to the receptor is continuously changing. So that also explains why in every different population, you see different dynamics of the epidemic. And sometimes there's a flare-up in country X, then there's a flare down in country Y. It goes on. And that's because of the mutations and selections, the biology of the virus and its receptor. Well, one very dangerous one is, of course, the British variant, which was announced by Boris Johnson in early December, well, December 19th, just before Christmas, and which basically ruined Christmas parties in the UK for that year. It was a virus that came up very quickly. You can see it's rising very quickly, and it apparently was very successful in spreading around. And why would we be worried about those variants, those mutants? Well, because they transmit more easily and therefore are more infectious. They might also cause more disease. And so people end up in hospitals, pathogenicity is higher, and they could escape the immune responses and therefore make vaccines, for example, less effective or reinfect people. And also the diagnostic tests that we develop to find out whether you're infected, they might fail on variants and mutants. So there's quite some reason for concern. And here we see different variants of the virus, how they are spreading all over the world. On the left-hand side, we see the variant from Britain, which basically is all over the world now. We see in South African variants, and we see in Brazil variants. They're spreading like bushfire. What about transmission of COVID? How does it go from one human being to the other? And what is so special about COVID? Well, I would like to concentrate on the picture on the right bottom, where we basically can see that if we look at a typical COVID infection, with viruses going up and viruses going down over a couple of weeks in an infected person, then the red dots indicate that this virus, SARS-CoV-2, coronaviruses of today, they are already infectious a couple of days before they are really detected and symptomatic. Day 0 is the moment that you find your first symptoms. But you see, this virus is already infectious before those days. In contrast to MERS and SARS, you can see that at day 0, they still are not yet infectious. In other words, this coronavirus is special because 2 or 3 days before you feel something, you can already spread the virus. And that is, of course, good for the virus because it can, it's hidden and therefore can move over very quickly to other human beings, but it's bad for human beings. It is a two-stage rocket. The virus first goes into your nose and it infects certain cells in your nose, and then it replicates in your nose, and then automatically by breathing it gets into your lungs, and that's the second state of infection. And there are 2 types of cells in your nose that are specifically vulnerable to the virus, and these are the so-called secretory cells, and it are the ciliated cells, and you can see them here enlarged. And the secretory cells, they make the fluids in your nose, and the ciliated cells, they move dust out of your nose when you're breathing. So they have small cilia, they can move. And those 2 cells apparently are very, very vulnerable to the virus. That's a clever trick of the virus. And then how is it transmitted? Well, basically by singing, talking, breathing. And there are basically 2 types of transmission that play an incredibly important role: the big droplets and the small droplets. In other words, there are big droplets when you talk, and those droplets, they usually fall on the ground within 5 seconds, and they don't reach further than 1.5, 2 meters, 2.5 meters maximum. And that explains why we have the 1.5 meter society and try to keep distance from each other, so that the big drops with a lot of viruses fall on the ground before they get into your nose. Of course, masks can also protect against those big drops. And then the small drops, they're called aerosols. They are 100 times smaller and they stay in the air, sometimes for hours and hours, sometimes for 10, 12 hours in a room. So to protect yourself against those aerosols, you need ventilation. Architects, rooms have to be ventilated well. That is the building of the future if we talk about corona. So ventilation, as well as social distancing and masks, are the ways to protect yourself in first place against the virus. Another thing, of course, here we see a good example of ventilation and architecture. This is a restaurant in China, and there was a patient sitting at this particular table, the purple patient, the index patient, and that patient apparently infected 4 other people around his table, 3 other people in the table next to him, and 2 other people in another table next to him. Well, other tables in the restaurants were not infected at all because there was air conditioning, there was outdoor air, and there were doors open, so there was good ventilation here. So here's a typical example, well-known example of a poorly ventilated area in a Chinese restaurant causing aerosol transmission of the virus. So this is also important to keep in mind for architectures. And another one another one is, of course, sewage water. It is possible to measure COVID in the water of the sewerage. And here we see in the Netherlands, people measuring water. You can easily see in orange here that peaks in COVID viruses predicts peaks in hospitalization and peaks in infectivity in human beings with 1 or 2 days, 3 days sometimes. So in situations where there is a real advanced sewerage system, then that is a way to really manage the epidemic and predict in which parts of the city, for example, there are outbreaks. Maybe also of interest, the buildings of the future should have certain sewerage collection points for future outbreaks, where we can measure outbreaks earlier than on human beings. What about clinical? What's happening with the clinical situation? Well, basically, when you are infected with a virus, it takes on the average 5 days or so to develop symptoms, if you develop symptoms. Here we see Anthony Fauci, the big star in the United States, who is the COVID expert. I stole this slide from his presentation, but you can see that that for some people it takes 10 days before you get symptoms. And for quite some people, you don't get any symptoms at all. If you get symptoms, then usually they are quite aspecific, fever and cough and fatigue and anorexia and shortness of breath and myalgia, your muscles are painful. These are the normal features, but you know, this also happens when you have a flu. So it's quite difficult to recognize COVID. One of the things that is very specific for COVID is loss of taste and loss of smell. So that if you have that, then definitely there's something going on. And I'm not going to go into any details of this slide, but basically I want to tell you that COVID is a disease in two stages, the blue stage and the red stage. The blue stage is when you just get infected by the virus and the virus gets into your nose and into your lungs and the virus is replicating and you get real viremia and the virus is destroying some of your tissues. And the second stage is your own immune system reacting to the virus. And what happens is that sometimes your immune system gets out of hand. It cannot handle the virus. It is just confused. And it keeps on replicating and creating all kinds of immune reactions. And in fact, those real immune reactions are the ones that create very big sickness and that can make you end up in a hospital. And this is something that I would like you to keep in mind, because in Africa, immune reactions are different. And I'll show you that. So basically, the virus comes in, and it can destroy and it can really affect all kinds of organs in the human body, not directly because the virus is already gone, but indirectly because of the immune reaction. Another thing that it's doing, it gives a lot of mental problems. Here we see in 400 patients in Italy that almost 30% of them got post-traumatic stress syndrome because of COVID. 31% had depressions, 42% anxieties, and 40% insomnia after a COVID infection. And this is not only because it is stressful to get COVID or to have COVID around in your family, but also because the virus directly infects your brain. It can use the nose neurons in your nose to jump into your brain and really affect your brain competence. Not always, but it happens in 1 in 7, 1 in 8 people. So that is a very important feature as well. And the thing is that there is a relation between depression and lack of smell. So people who lose their smell and their taste, they usually are more depressed. Here we see a depression scale. Normosmics are people who have normal smell, and anosmics are people who have no smell. And COVID creates this. And so we see more depression in people who cannot smell. And that's so interesting because in biology, what is smell and taste for? Smell and taste are there to protect us against fire. We can smell fire from a distance, or against wild animals. We can hear wild animals, or we can react to that. And also the smell and the taste of, for example, poisonous food. If you eat it, you spit it out. So smell and taste are protective mechanisms. And if you lose them, you get worried. Somehow inside you, your mental state changes and you get worried. Another important thing is if you have had COVID for 1 or 2 weeks, then a lot of people have so-called post-COVID syndrome. In other words, they remain having symptoms sometimes for 3, 4, 5, 6 months. Here we see people when they get infected with their numbers of symptoms in different bars, and how do they move over 79 days later after infection. And you see that people still have quite some symptoms. Not everybody, but quite some people do. So it looks like after the wave of COVID, there will be other waves of diseases. And we see that happening now in Europe and the United States of post-COVID diseases. Okay, let me ask Brenda, are there any burning questions at the moment, Brenda, or can I continue?
No questions yet, you can just continue.
Okay, well then I'm going to say something about fatality here. How deadly is COVID? And in fact, we can see here in the yellow line, according to age group, that for the younger people up to the age of, let's say, 50, COVID is negligible. It is not really important, it doesn't cause death. But after age is going up, then COVID can create quite some fatalities, particularly in the age group higher than 80 years. So overall fatality is in the range of 2% worldwide, but for people above 80, the chance is basically 1 in 4. 1 in 5 to get 1 in 6, in that range, to get really into a serious situation. Also, the virus does not spread like the left picture, but like the right picture. So the so-called super spreading. Maybe you've heard of it, but quite a lot of people, in fact, although they have COVID, they are not infectious to other people. So if we look at the so-called R0, which is the kind of replication rate of the virus, for COVID it is 2.5. And that means that 1,000 people infect 2,500 people in the next week, okay? If nothing is done, if you don't take distance, if you don't take mouth caps and so on. But in fact, if you look in more detail, then out of those 1,000 people, there are 600 people who are COVID positive who don't infect anybody at all. There are 200 people who basically infect 500 people. So that's an RO of 2.5, 200 to 500 times 2.5. And the other 200 people, they infect 2,000 people. They have an RO of 10, like you can see here. In other words, these are super spreaders. And that's the way typically coronavirus is spread. And super spreading is not rare at all. It takes place all over the world in all kinds of situations. It has been recorded. So super spreading is really an issue. And nowadays, with our vaccination campaigns, and here's just an example, the big question is, we see an example in the United States with the coverage rates of vaccination. We always thought that herd immunity, group immunity of the total population will protect us from corona. But with those new viruses that we're talking about, possibly the RO is more than 2.5. The R0 is in the order of 4 or maybe 5. And that means that 80% of the population needs to be vaccinated. Well, that will not be possible. We can see it already in the United States. Vaccination campaigns have been going up very quickly under Biden. They have vaccinated a lot of people. You can see it in purple. But in light purple are the areas that are not that vaccinated very well, either because people refuse to be vaccinated or because there are logistical problems or other problems. So you can see that there is, and there will always be, uneven spread of vaccination, and therefore pockets of places where herd immunity is not reached. And that's where viruses can flare up again. And this is the example for the United States, but it will be the same for other parts of the world. Where are we today in the world? Well, we have more than 150 million infections. These are the WHO data, and more than 3 million deaths. Here we see the so-called Johns Hopkins coronavirus resource site, which is the biggest one and the most up-to-date one. 152 million people infected. This was, I think, the day before yesterday that I took this slide. And 3 million people died of the virus. But of course, these are underestimations, and we don't know the exact figures because reporting is not always that good. And what is the underestimation? And maybe there's much more people infected. Well, there's one paper that just came out in Nature, an important journal, that tried to estimate the average infection rate worldwide by taking hundreds of studies together and come to an average figure. And the average figure, in fact, is 8%, which means that if we look for antibodies against COVID, so that is the immunological history of somebody, then you see that 8% of the world at this moment has had COVID. And if you multiply that, you come to, with a world population of 7.8 billion people, then you end up with something like 650 million people. That is 4 times more than the official records. So what we see here is probably, it's certainly an underestimation, and probably the number of positives is 4 times higher. And so also the number of deaths is probably 4 times higher. We're talking about 10 to 12 million people. So that is a serious epidemic. Where are we with vaccines? Well, that has been a miracle, of course. In the last year, vaccines were developed very quickly. Here you can see that in the year 2020, various different vaccines were in less than 9 months they were developed, compared to all those other vaccines in the past, how much time it took to develop them. That is really a miracle. And why did it happen so fast? Because the technology is very advanced nowadays. Just imagine that this outbreak would have taken place 20 years ago. Then we would have been in a completely different situation worldwide, with no vaccines available and a massive additional number of deaths and sick people. So in a way, we are lucky that we can build on the existing technology. Of course, also a lot of money was put into the development of the virus. In fact, in 1 year time, there was 50 times more money spent on COVID vaccines than on the entire HIV vaccine research over the last 25 years. So it shows also where the priorities are in the world. When a virus infects the whole world, suddenly money is available. Look at malaria, which is just basically a disease in Africa and in poorer countries. Not even 1,000th of the money that has been spent on COVID has been spent on malaria vaccine development. We have the first promising vaccines coming up now, but it takes ages and ages. So that is a very grim conclusion also. Vaccines are prioritized for people who can pay for it. Here we see where the vaccines are. We have Pfizer, Moderna, Johnson, and Oxford. These are the 4 approved vaccines in Europe. Then there's the Sputnik vaccine from Russia, Gamaleya, and there's the Sinopharm vaccine from China. And all of them are now in the process of being approved. Although the 4 ones from the West are the most important ones, at least in Europe. And the Oxford AstraZeneca vaccine is the one that is the most likely for Africa to be used in big numbers. But we heard, of course, also some negative news about those vaccines. So I wanted to get rid of that negative news and give you this picture which summarizes everything. If you look to the left, then these are the percentages of efficacy that you read in the newspapers. Pfizer and Moderna, the new RNA vaccines, are very efficacious, 95, 94%. That's what you read in the newspapers. Sputnik, the Russian one, is also very has a high efficacy, 92%. AstraZeneca is only at 67% and Johnson & Johnson at 66%. So it looks like there are kind of first-hand and second-hand vaccines. But let's keep in mind that these are clinical trials done in laboratories in very controlled conditions. And if you look at what is in reality needed, then the only thing that we want vaccines to do is to stop us from getting hospitalized and stop us from dying. So if you look at death and hospitalization, then suddenly all vaccines are working 100%. Okay, so I wanted to give you that message very well. All of those vaccines are good. They all will prevent hospitalization and death. They might not prevent mild symptoms, but we don't care about mild symptoms. It doesn't matter to have a little bit of a flu. And if we look at the first big studies done in Scotland in real life, where they used basically Pfizer and AstraZeneca vaccines, here we see the time periods and the age groups in Scotland. 5 million people already vaccinated. Then you see that AstraZeneca, in fact, in real life was much more efficacious, 94%, than the Pfizer vaccine, 85%. And so that's the opposite of what we see in the clinical trials. In other words, don't let yourself be distracted too much by those percentages that you read in newspapers. The message basically is all vaccines that are approved at the moment work 100% against hospitalization and against death. 99.8%, let's put it like that. There's never a 100% in biology. And the whole blood clot story of AstraZeneca, keep in mind that this is about 4 cases in the 1 million. So we're talking about 0.0004% risks. Well, if you take the birth control pill, your risks are already much bigger for blood clotting. If you smoke, your risks are incredibly much bigger. And by the way, if you get infected by COVID, the risks are even bigger. In other words, it is a completely negligible risk, blood clotting. And many other vaccines have similar side effects. So there is a kind of a hype in the press, which unnecessarily makes people afraid. And I wanted to tell you that. Also, the Pfizer vaccine, we know now already for more than 6 months, it works. Probably we're moving towards a situation where vaccination will be needed once every 1.5 years for the future. Well, every year, every 1.5 years. The vaccines will protect for at least a full year. Who did pay for vaccines? Well, there was private money, there was government money, and there was not-for-profit money invested. AstraZeneca, for example, was mostly funded by private investments and also by some government investments. The Moderna vaccine is quite interesting in the United States, was completely paid by the governments and thus by the taxpayers of the United States. And in that sense, there is a big pressure at the moment ongoing on President Biden to make that vaccine available for the world, because it has been paid for by the taxpayers in the United States, by people. So it should be, the patent should be released, and other production sites in South Africa, in Brazil, in India should basically be able to produce this vaccine instead of protecting the patent and earning money on it. So there's huge political pressure at the moment ongoing in that particular vaccine area. How do those vaccines work? Well, let's not get into the details, but they basically imitate the virus. And so they have a little piece of virus RNA, just a little piece, in small vesicles, which are can fuse with the cell membrane, and they just get into the cell and they get into an immune response. And just to show you what is in a vaccine, for example, the Pfizer vaccine, it's basically 11 ingredients. And we don't need to know all those names and so on, but people want to know what is in the vaccine that I get when I get a vaccination. Is basically the active ingredient, which is RNA of the virus, which is specific for the virus, the spike protein in this case. And there's 4 different lipid nanoparticles. These are lipids, difficult molecules that make the small lipids that you saw, those small vesicles here, which are carrying the messenger RNA. There are 4 different salts in blue, which prevent the lipids nanoparticles from disintegration. There is antifreeze because the sucrose, because the virus has to be kept at -80, and there's water. So this is basically what is getting into your body if you get vaccinated by an RNA virus. And vaccination, of course, is hot. It's ongoing, and it is a huge challenge in Africa. I'll come to that in a second. I'll have 4 more minutes for my presentation. But we're working now towards yellow cards and the yellow booklets of vaccines. Probably that will be a QR code in your phone. And yeah, it looks like our future traveling will be with a COVID-19 travel pass. But this, of course, will mostly be the case for people from the Western world to start with. And there's a lot of unfairness in that. And if you look at Africa, well, in a way, Africa looks less affected because 1 in 6 people in the world is an African, but only 1 in 30 of the COVID patients in the world is an African. So it looks like Africa has less COVID. But is that really true? We see, in fact, that there is a second wave in Africa in January, February, and in some countries, a 3rd wave is coming up. Certainly in Kenya, there is a 3rd wave ongoing now, today. And I'm sure Dr. Simon is going to talk a bit more about that. So there is COVID in Africa. And we see basically that there are lots of new cases reported. And this is by John Gengasong. John Gengasong is in Addis Ababa with the CDC Africa. And I stole this slide from his presentation. We see huge numbers of outbreaks of viruses in different parts of Africa, and also fatality rates are sometimes really high. Look at the red countries, look at the brown countries. These are countries with very high fatality rates, between 2 and 5%, higher than in Europe. Okay, 44 out of the 56 member states of the OAU have at the moment a 2nd wave of COVID ongoing. So it is there, definitely. And we also know that the viruses in Africa are mostly from Europe. We've seen that. And there is the South African variant that's coming up. Here you can see it in yellow. Over time, it has taken over the South African epidemic completely. It came from basically the Nelson Mandela Bay area. It went to the Garden Route. It went to the Cape. It went to KwaZulu-Natal. It spread all over Africa in a couple of weeks' time. And basically, the South African variant is not only now in South Africa, but look, it's in the entire Southern African area. And it has also been already seen in Kenya. And it looks like there is an outbreak of it already happening in Kenya. If we look at the British variant that I discussed before, that's somehow more in Western Africa, in Ghana, Nigeria, and in Northern Africa. But you see those variants, those mutants are spreading in Africa also, like bushfire. Still, my last part of my presentation, the fatality rates, the number of people who die of COVID and the hospitalization are relatively low. Here we see the world map, and Africa as a very small continent in terms of fatality. And that is interesting. Europe and United States and South America are much, much bigger. Asia, China is also not that much. Why is this? Well, I'll give you a couple of hints. What is different in Africa? And that's the end of my presentation. First of all, there were very early and strict lockdowns in Africa. And you know that much better than I do. Already in April, the army on the streets, curfews, lockdowns, people were really getting scared. And there was a lot of stigma then created because people thought, what is going on? Of course, this is now more than a year ago, so people are much more relaxed, but the very early reaction was very strict. So that has temporarily stopped the virus from developing in Africa. Also, Africans are much younger than people from my country. Look at the age distribution. Half of the population in Africa is younger than 18 years. And that's not the case in the Netherlands. Look at it. There are many, many more older people. So on the average, Africans are 25 years younger, and we know that young people suffer less from COVID. So it's logical. Also, we know that there is massive underreporting of causalities. The track records of people who died are poorly kept in Africa. We don't know often what people died of. It's not recorded, and therefore we don't know the actual figures. Another thing that I'm working on with my research team is helminth infections. I told you the immune systems of Africans are different, and that's because their immune systems are continuously activated. In fact, Africans have very strong immune systems because they get often infected with amoeba or with giardias or with helminths, ascaris, trichuris, tapeworm, because you eat food that is not completely hygienic, for example. It can happen, and that happens much more in Africa, as you can see on the right side of the picture, than it happens in Europe. But if you look at COVID, there's less in Africa and there's more in Europe. So it looks there is an inverse correlation between infections with parasites and COVID symptoms. And I've just submitted a paper about this to the Lancet, and I'm in a big conversation with the Lancet to get this published very soon. There's a clear relation. Also, we know that there has been already a lot of COVID. For example, look at Nairobi. There is certain parts of the city where there is herd immunity. 60% of the people, they have already had COVID if you look at their blood. And overall in Nairobi, 1 in 3 people has antibodies against COVID. In other words, you were infected sometime in the past and you just didn't even notice it because there were no symptoms. And then there's genetics. I'm not going to go into the details of that. There's limited diagnostic testing. Keep in mind, diagnostic tests for COVID are expensive. They're difficult to do. It's only recently that rapid tests come into the market. Rapid tests are cheaper, but there are pros and cons. So in fact, in Africa, we measured much less than in Europe. And, we possibly see in Africa the tip of the iceberg, and in Europe, we see much more. The last picture I would like to give you is about vaccines. We know that there are vaccine challenges for Africa. And there is this so-called COVAX mechanism, Corona Vaccine Initiative, which is there to purchase vaccines and to spread them more equally all over the world. And if you look at countries like Canada, they procured almost 9.5 times more vaccines than they have actually in population. They procured 360 million doses for 38 million citizens. And we see now that Canada is vaccinating rather quickly, but of course it's over the top. New Zealand, same story. The UK, this is in Dutch, UK 5 times more. European Union 3.6 times more. COVAX, unfortunately, still is at 0.6. In other words, COVAX has secured the procurement of 0.6 vaccine per person living in Africa. That's not enough. It needs more money and it needs more investments. But even there, even when the money is there, the vaccine should also be there. And the production of AstraZeneca, which is the key vaccine for Africa, as you know, is not that high at the moment because of all these scandals and issues that took place. And also because India, which is the key producer of AstraZeneca for Africa, is in a huge epidemic itself. And India is not exporting its vaccines at the moment, or hardly, because it needs the vaccines for its own population. And who is paying the price? Africa. Well, I just would like to thank you for your attention. It's highlights. I know it is a lot, but I thought it's good for you to have a bit of a general background. This presentation will be available for you. Of course, you can have a look at it, and please feel free to use it with family and friends if you like, to explain them a little bit more about COVID. And I gladly give the floor back to Brenda. Thank you very much.
Thank you so much, Professor David. That was an insightful presentation. I'd like to welcome any remarks and reactions in the chat box, and you feel like you want to ask a question yourself, feel free to just raise up your hand in the tab below. I'd like to just highlight a few reactions to the presentation, but before then, I'd like to just thank the members of PharmAccess I'm seeing here. I can see Sabine, I can see Irene and their team. Also, I'd like to recognize the presence of our Vice President of AAK, Architect Florence Nyole. I can also see we have other corporate members from AAK. We have our graduates here also and some students, which is very impressive. A few reactions. Before the reactions, also I can see there's Dr. Christine Murungi, consultant obstetrician and gynecologist. Welcome, Dr. Christine. I'm sure there are also other doctors here who are interested in just learning about the connection between the healthcare and the built environment. A few reactions. Architect George Yagomba says he is glad to be a participant in this insightful masterclass, and that's a good reaction for this introductory presentation. Also, there's a reaction I saw by Architect Shamla Fernandez. She mentioned that this is, I'm trying to find the chat. She mentioned that this is, she says, thank you for this webinar. So thank you to AAK and the Secretariat and also PharmAccess for organizing this. Any other reactions and questions, feel free to type them out in the chat box. And without further ado, I would like to introduce the second presentation. Then we can take the collective questions and reactions in the end. Okay, so Dr. Onsongo, I hope you're ready. Welcome, welcome. Also, just a housekeeping, we'd like to also include your Borax, your AAK numbers in your names on your Zoom name for ease of allocation of CPD points. Okay. So please make sure you add that so you can easily register you in case your name is not what's showing in your participants list. I can see some other names, mom and dad. Make sure you have your official name so it's easy to record your presence. Thank you. So Dr. Onsongo, over to you.
Thank you. Thank you so much. Good morning again, everybody. And I want to take this opportunity to thank AK and PharmAccess for reorganizing this forum. I think for me, it's a pleasure, and I'm truly humbled that I've been able to be a presenter to this wonderful group of people. Prof has really tried to summarize this, and my aim is really to look at the COVID pandemic in Kenya and its impact in healthcare facilities in the country. I really want to go through a quick introduction, just summarize on the state of epidemic in Kenya. Prof has really again tried to really go through it in a wonderful way, and that makes my work very easy. And then I will try to look at the health ecosystem, just being a bit local. How is the Kenyan healthcare organized? And look at how COVID diagnosis is made. And at the end, share some experiences from Aga Khan Hospital, Kisumu, which I think will be giving us insights on how this COVID has been handled in practical aspects in the country. So we know Kenya, we have population, one of the most populous countries in East Africa. I think our population must be almost 50 million by now, because 2019 it was 47.5 million. A lot of people live in below the poverty line, that's around 36% of the population, and 65% in urban areas, in rural areas. That means that access to care might be a challenge in most places. The country healthcare system was changed around 2013 into two systems, where you have the national level and the county level. So there was devolved system of healthcare delivery. The other aspect that we need to is that the healthcare system in Kenya is pluralistic. That means that there is a mix of private and public in almost equal share. And where the people who provide healthcare include public facilities in almost half of the time. And then the rest is a mix of private hospitals, mission facilities, and even non-government organizations. So healthcare in Kenya is quite mixed and really helps to improve the health of the people. In terms of metrics, if you look at the Kenyan healthcare system, it's really interesting. We still have milestones to make, areas to improve. Look at life expectancy expectancy at birth is around 62 years. That's according to the World Bank. And under 5 mortality rate is still high, and even maternal mortality rate. So the numbers are not so good. And even the amount of money we spend on healthcare is still very low. I remember that if we want to really provide good healthcare, we must spend the money in the healthcare to be able to improve it. Without money, you cannot really be able to provide decent healthcare. And I want to draw you to the percentage of 3.5, which is really the percentage money is allocated from the budget to provide healthcare to the people. 3.5 is very low to what is supposed to be 15%, or at least 15% to provide good healthcare. So we still have areas to plug in, and really when we got the pandemic, I think it was really a challenge because already the healthcare was already stretched, and I can see that some of the healthcare facilities really struggled to cope. What about how the healthcare facilities in Kenya are organized? So if you look at this table, just to summarize how the healthcare system is organized in the country. So we have sort of 4 levels of healthcare, but around 6 levels of facilities. So level 1, of course, is the primary, the basic community healthcare services in the village, then followed closely by the dispensaries and healthcare centers, which are small facilities that are supposed to support disease prevention and sometimes creative services, really basic infrastructure. Level 4 and 5 are really more secondary care facilities. These are the county hospitals that and some of the bigger facilities that provide more comprehensive care that covers both surgical and medical cases. And then, of course, at the top is the tertiary care hospitals. That's level 4 facilities that really provide the highest level in the country. This is super specialties. And these are the Kenyatta National Hospital and the Moi Referral and Teaching Hospital in the country. So we are at the peak level, and these are the ones that sort of train people and lead in the healthcare delivery. So that's how the healthcare is organized. And this could be really important in terms of how various conditions emerge in the country. And it's so important to look at this in terms of effectiveness of handling some of the COVID cases, as we shall see as we move forward. For us, I really want this important is really to look at the healthcare system in terms of how can you deliver a good healthcare system. You really need these 2 pillars. One is the hard elements of the healthcare system, and of course the second element is the soft elements. I think the hardest bit for Kenya is really the hard elements that we're still struggling to get into place. Things like infrastructure, having an available, well-trained and motivated health workforce, and having health supplies and commodities that are really going to support healthcare. So this is a very important cog in the healthcare delivery. And the other bit to note is that the hard elements are not easy to get going. You have to invest a lot of resources, a lot of time to be able to get. For example, training doctors or nurses or healthcare workers takes time to get on board. So it's not something you can change suddenly, and that's why they're called hard elements. The soft elements are easier, but still very important because things like logistics, coordination, policy, communication are still really important because without them, again, you'll not be work in an orderly manner. So the 2 elements are really important in healthcare delivery. The other thing that I wanted to mention is that we really aim, at the end of the day, the aim of healthcare system is to serve the people. And we really have to listen to what the patient or at the time of their illness needs. And as a healthcare provider and as a team here who are in charge of maybe building the facilities or whatever your role is, we really aim to make sure that the healthcare facilities are patient-centered. So you have to look at the facility in terms of how to access it. Is it able to support the patient? The patient must have a good experience as they go through the system. They must have a bit of privacy, because as you go to hospitals, you have to make sure the patients feel comfortable. And then, of course, must facilitate the communication between the patient and their clinical teams, who could include the nurses and the doctors and the other people there. So really, we really need to think about patient-centered care in our facilities as we design them, as we make them, to really deliver good healthcare. So at the moment, just know that good healthcare must be patient-centered. And if you walk around the country, you notice that that's not really the case in most cases. So I hope that it could be a lesson that as we move forward, we really think about the patient being at the center of healthcare delivery. This slide, I put it up just to really show you that you need a lot of elements to be able to have good health outcomes, which is the end product of a good healthcare system. So when you have good financing, you have good governance, you have good infrastructure present, you have good healthcare workforce, good supply chain mechanisms, all the hard and soft elements coming together, eventually we will get improved health outcomes, which is really our wish that we get. So that's really a product of many, many things. And we really have to work right from the beginning, from financing and governance, and then drive up to the healthcare delivery, which is the final, having people who are healthy and living good lives. So quickly into the COVID pandemic, I think Prof has really covered a lot of the biology and the presentation, which is it makes easy for us to jump into the pandemic and its effect on the healthcare systems. You know, as always, epidemics, as the Prof highlighted, since the various pandemics we've had in the past, they really make a big challenge to healthcare systems. You know, and the critical aspect of any country is how to respond to a pandemic and ability to manage the increase in patient numbers. So your health system must be designed in a way that is supposed to cope with the surge in numbers. And we know for sure that today, many of the healthcare facilities in the country are not designed to handle a surge in numbers. You know, if you go to most hospitals, you find they're 90% full, 100% full in terms of occupancy. So we really don't have that extra capacity to be able to cater for pandemics. So like what's happening in India now, the moment you can see in the media, you see a lot of patients going to hospital and they can't get a space. There's no facility to cater for those patients. So it's a really a big thing to think about. It's a big challenge. It's not easy to really get a solution around how to increase that capacity all in a very short period of time. So indeed in Kenya, COVID was really a stressor. I can say a great stressor to healthcare facilities, because already those healthcare facilities and the healthcare workforce and the infrastructure was already stretched. Okay. The other thing to note is that the Kenya system has a lot of disparities across populations. So different people have different levels of access. Some people have there's a lot of inequalities in the system. There's a lot of poverty. We said a lot of, almost at 6% are below the poverty line. So that really makes it difficult for these people to be able to get good care. So we really have to think the pandemic as having aggravated this ecosystem that's already at its, was already stretched. I wish not to go into a lot of the numbers, but as you can see, I want to share this graph to show you that Kenya has really gone through the three waves that we are seeing here. There was the initial wave that came in the country, and then there was a second wave, and then because of the mechanism the government took in place, there was sort of a reduction in the cases. And there's a third wave, which is now, we're in now the third wave. So you can see the government mechanisms really come in, they reduce the viral transmission and the effect of the virus in the community. And then once the mechanisms are removed again, sort of the pandemic goes up. This could also be because of the new strains that are coming in the country, like the South African strain, could be that causing a lot of increased transmission in the country. So a lot of these cases are really showing the various waves we're seeing in the country. The number of deaths so far is 2,700, and I know Kenya records quite the number of deaths quite accurately. So I think that is the figure might be correct. It's lower than we expected, which is a good thing. We hope that the number of people who die from this COVID really continues to decline. So how was the MOH response? And I think it's something that we are proud of, is that the Ministry of Health in Kenya has been leading the fight against the pandemic. And I think they put in strong mechanisms really to try to tackle it. I think we didn't like the lockdowns and all those things that the government did. They were not very pleasant, but I think if they had their impact and they were very good. There's also a lot of partnerships, Kenya with other local and international partners that have worked together to really sustain the fight against the pandemic. People like the CDC, African CDC, World Health Organization, and other international organizations have really come in to support the country. So we really appreciate such kind of efforts. The other thing is that Kenya has had a lot of diseases in the past, like HIV and TB and the malaria. And these diseases, the experience in managing these infectious diseases came in handy when the pandemic came. So they already have teams of experienced healthcare workforce that sort of has had these challenges before. It was easy to just be able to have a support system that can really tackle the pandemic. So having a experienced workforce is really an important aspect in managing the COVID-19. The other thing that we really appreciate, which I, at even a personal level, the issue of effective communication. I think we've had the Ministry of Health really communicating effectively in terms of the disease, the case definition of COVID in the initial days, looking at who has COVID, how do you suspect COVID, how is it transmitted, and what measures can we take to prevent it. And there's a lot of almost, every day, updates on the COVID situation in the country. And that was really through the role of social media and the mainstream media. And that I think really helped a lot of Kenyans to become aware of the disease and be able to manage it better. So effective communication is really another pillar in terms of tackling this pandemic. So I just wanted to highlight some of the common challenges that we face. And this is really challenges that affect healthcare facilities in particular. And this really cuts across whether you're private or you're in the public sector. I think these are challenges that cut across. One top that really comes to, I want to challenge the team here is really the issue of facility challenges. Across the country, there's a limited space in healthcare facilities. The design of the structures still need to be improved and be better in some of these facilities. How patients come in, how they flow, the kind of infrastructure there to support the care has sort of remained stagnant for many years. The hospital design in Kenya sort of stagnated, yet there are a lot of other new additions that have come into hospitals, particularly supporting safety mechanisms for patients who come to the facility. So facility challenges came in when COVID hit. This was really obvious.
The design is from the 1960s.
Okay. Then access to healthcare services was a challenge. Some people really have to travel long distances. Cost of testing was expensive, cost of admissions. So, most people are very poor. So accessing a test for $100 or 10,000 shillings is really not even something to think about. So that's a challenge. And we know that a lot of Kenyans don't have insurance. So lack of insurance, all this make access becomes a big challenge. The lack of supply is also a big problem. A lot of the companies, we know a lot of companies which were importing things from other countries and they had a lockdown. So PPEs was a challenge, medications not available. Diagnostic kits for COVID, that was a difficult thing to get. So I think the government had to look for other ways to suppress the pandemic, because looking at the supplies, initial days was really a challenge and we couldn't even get a diagnosis going. So I think the lessons as we move forward, we really have to think and be innovative in terms of how to sort some of these problems as we go forward. Again, I've mentioned about vulnerable populations. People are disproportionately affected by the pandemic. People who live in the slums, people living with the disabilities, people living in remote places. All these people really are very vulnerable to the pandemic. Personnel issues are still there. So we have really, if you look at the population of staff who provide healthcare services versus the population, the numbers are not very pleasant. So we really have to really think about how to sustain an adequately trained and available workforce. Okay, so who can be able to really support the product provision of services. Switching on to in terms of the capacity, again, this is an example of hospital beds per 1,000 people. So you look at these countries, I just picked a few of them. You can see Italy, Kenya. Kenya has a capacity of around 1.4. This is an old survey, but it's still relevant. 1.4 beds per 1,000 people, compared to countries like Japan that have like 13, beds per 1,000 people. So even the indicators are showing that we're still struggling in terms of bed capacity. If we have to have a surge of COVID patients, then we won't have a place to put our patients on. These are recent surveys also done last year, as a study just to assess the state of the country. You can see Kenya has a total of 64,000 beds. So if you are to get 1 million Kenyans sick, only 64,000 will be admitted in those hospitals. Okay, and if you look at the distribution of these beds, only 58% have access to oxygen. We know COVID, it's a respiratory illness. Sometimes people require oxygen to be able to survive. So access to oxygen and bed to the oxygen is still a challenge. The other thing is that a lot of these countries don't have intensive care facilities. So only 2 out of the 47 counties have access to at least 1 ICU unit in each county. So of course that says that we really need to think about that as we go in the future. The other thing I wanted to mention on this side is that access in terms of distance to be able to access services sometimes can be a challenge. So you could have an ICU facility in your county, but it's very far away from you. And when you have a sick patient who needs to access hospital quickly, that is a factor that can make life, can lead you to either living or dying. So it's a big challenge, and we really have to think about capacity. We have to be innovative and think about how best we can prepare our facilities to receive COVID. I just want quickly to go through diagnosis. As a doctor, I'm always biased towards diagnosis and management of COVID. I know Prof has touched a lot on this, so I'll just quickly go through it. He talked about the symptomatology. I'll not really dwell much on this, only to mention that it's really a spectrum from very mild conditions to a mild disease to can be very severe in some patients. So it's something to think about. And I think we've talked about the incubation period. It takes around 5 days to get symptoms. This slide just highlights again age being a major factor in COVID severity. So young people, as Prof really highlighted, is that young people are more able to withstand this virus with mild or no symptoms, whereas people who have other comorbidities like cancer, hypertension, heart disease are more likely to get very severe disease. Okay. Again, you can see the number of days. The people who get severe disease, it occurs around day 8 of the infection. People who get critical care and admitted to ICUs, it occurs around day 16 on average. So this is just a chart to summarize that aspect, and I think Prof has really discussed it as well. Again, this is just to show the presentation that asymptomatic people are like to be younger, okay, and of course more fit. As you get older, you tend to have more symptoms and more disease. Okay, so how do we diagnose COVID? Really, 3 aspects. These initial days, we had a lot of epidemiological, where you gone to, or you traveled from a place where there was COVID. Initially, it was from China, but nothing COVID is everywhere. So epidemiology doesn't be a big factor because COVID is all over, which Prof has really touched on. So we have to look at what symptoms the patient is having, and then also we do a confirmatory through PCR, which is polymerase chain reaction, or more recently we're having antigen tests can also be used to diagnose COVID. The other tests that can be done in hospitals, these are really supportive tests to help with. So this chart again just tries to summarize those things. On addition, people do imaging as well to look at the chest, they look at your lungs, and that also is an additive test that really helps clinicians. So you look at your symptoms, look at your lab diagnosis of your to check if the virus is present, and of course imaging findings. That way you're able to confirm COVID. I just want to mention this because PCR is something that is important in COVID. It was one of the first line defenses against COVID, because without a test, we couldn't tell whether someone has COVID or not. So PCR became central, and a lot of hospitals in the country really struggle with having PCR, and the PCR is really a very important technique. Yet it's really underdeveloped in the country, with very few facilities really offering the service, mostly in research institutions and the bigger hospitals. So a lot of the country healthcare facilities struggled with really this challenge of PCR. And indeed, PCR is an expensive sort of infrastructure to have, which is lacking in most places, and it really requires a bit of some design things, which will be important for these members to know, so that you're able to have quality results and also reduce contamination. So you can see the PCR operations divided into spaces, and these are separated out by physical barriers. And of course, this is just to avoid contamination that can easily occur with PCR, because it's really amplifying very small amounts of our DNA to large amounts, and there's risk of contamination. So this is really something that we are developing. Even the hospital where I work is really starting to build capacity around this. Again, not much I want to put on antigen tests. These are really rapid kits similar to the HIV kits that we use in the country. So you just put a sample and run it in around 10-15 minutes, you have our results. So they are easy to do, but of course they have their challenges in terms of their sensitivity or ability to pick all the cases of COVID. So if you have a negative antigen, it doesn't really exclude you having a COVID test. They put this up just to show the timeline of various, like how the symptoms come in and when your tests become positive. So for PCR and antigen, really it's around day 5 when you're still having symptoms. That's when you really start getting a lot of people becoming positive for the test. If you pick the sample very early in the disease, like on the day you get the infection, you might get a negative test. But once you start having symptoms, and then if you do the test, you are likely to pick up the virus. And then, of course, there are other antibody tests, which are not really important diagnosis. So a lot of this requires innovation. We say, this is just a slide from Aga Khan Nairobi that really needed to expand the bed space. So what they did, they went to the field next to the hospital and just put up a 100-bed facility to support patient care and in anticipation for many cases of COVID patients. So we really have to really think outside the box and be innovative as we do this. So I want to quickly go through the experiences from the hospital. And this is really part of what we went through. It's really a journey of COVID, very challenging times, but we managed. So Aga Khan Hospital is based in Western Kenya, for those who don't know. It's a 70-bed hospital with a small outreach medical centers across Western Kenya, and really provide a lot of comprehensive care for patients. In terms of the patients we've had the capacity to bed capacity only 12 beds, okay, and only 2 acute care beds. So that means that if you have 2 patients who need ventilation, you can't get more than 2 at any time. Okay, that's how limited capacity can be in the region. Okay, our first case for COVID was in the hospital was 16th June. That was last year, and since June till today, we've had around 176 patients who have had COVID. 5 of these patients have needed intensive care, while 14 have been mostly on HDU, which is high dependency unit, where you have a lot of close monitoring. The number of deaths is 16 due to COVID. That's around 9% of all the COVID admissions. Of course, the mortality is higher because there are really sick people coming to hospital. And of course, there is higher risk of mortality as opposed to the hospital mortality rate, which is around 2% or less. Okay, so that is just a summary of the number of patients we've had in the hospital. In terms of hospital experiences, the hospital really had a lot of a lot of day-to-day make changes to adapt to the situation that was changing. So you really have to be very dynamic. Looking at things like infection control and prevention for staff, trying to protect your staff at the same time provide care, screening patients and limiting people coming to the hospital. So there's a lot of challenge around infection control and prevention for the hospital. PPEs were a challenge initial days. Okay. We also had challenges in diagnosis and confirmation because the hospital didn't have capacity to do PCR on site. So you have to send out the test, and that takes 2-3 days to get a diagnosis, and that really delays care for these patients. But that is changing now. We also had challenges with patient placement, where we put the patients who have COVID, space is limited ICU spaces. So all these were really challenges the hospital had to face. And for the managers on the floor have to really be very agile and be able to make decisions every minute that comes. Again, I've talked about suppliers. These were really countrywide problem. Gloves are a challenge, PPEs were challenges, but at least at some point that became not a big mess like it was before. So at least now things are becoming more available. Okay. The other thing is that which affected other hospitals in general will be the reduced workload that came with it, because a lot of people feared coming to hospitals now. So hospitals had reduced revenue and could not support even some of the operations. So some hospitals had to sort of do salary reductions for their staff, which is really a stressful moment at that time when they're working much more. Remember, coverage for insurance by COVID was a challenge. I think some insurance still don't cover for COVID. So when you are sick with COVID, you may not have an insurance cover to protect you. So some of those are really challenges that came through. Staffing was another interesting aspect. So initially when COVID was coming to the country, people were really very scared of COVID. Even those people who had been trained and they were the experts. When they had the COVID patient, they never wanted to get near the patient. So that was a big challenge in the initial days. When you look at clinical staff, the non-clinical staff never wanted to be near this patient. So a lot of the clinical staff had to take the care of the non-clinical staff to be able to bring them food, for example, sometimes clean the room for the COVID patients. So that was really a challenge in initial days. I'm happy that people now sort of got used to the pandemic. Initially a lot of stigma. There was a lot of fear that was associated with the pandemic. The staff coverage was a big problem. At some point when you were exposed to the virus, sometimes you need to close down completely. So for example, you have exposure in theater, all of your team goes into quarantine. So who is going to operate the patient who comes next? So you have to really be thinking about how best to cover for those patients. Because of the quarantine periods was more than like 2 weeks, so people have to be away from work, and that really affected hospitals' operations, and it was a big challenge. Some staff got infected in the hospital. I think around 66 people already got infected by COVID, either through exposure to work or in at home, wherever they are going, because they live in the community. And if you look at the distribution of the those affected, it's really across all the departments that work in the hospital, from ICT to those who work in IT. It's not really nurses and doctors, it's really across board that were affected. So I think from Aga Khan Hospital Kisumu, the lessons that I really wish to share is that there's a lot of need to really to adjust all the time, evaluate your operations, make minute-to-minute changes, sometimes sustain care. At the height of the pandemic, you can't really you have to really be flexible, otherwise things can get out of hand very, very quickly. There's need to be innovative. Some hospitals have to be creative in terms of making things like hand sanitizer. When you don't have supplies coming in, you have to really find ways of making a way of surviving. Things like the transport media, making feed hospitals. Sometimes even people came up with the issue of sharing ventilators, because we didn't have ventilators, and you really have to find a way to ventilate patients who need it. Okay. There's need to constant communicate. Communication is a big thing in epidemics or pandemics, and you really have to have constant up-down across-board communication so that everybody is updated. Okay, and that really helps to allay a lot of fears. It also brings team spirit, and people can able to work in a better way. The hospital had really a lot of effective communication, starting from the CEO. We had constant meetings, and that really helped to allay fears and promote team unity. Partnerships was great. I think PharmAccess has been working with the hospital for many years now, even beyond, I think even before COVID. So having partnerships to work with when you're having stressful times is really important, and that is really encouraged. The last and not least is really supporting staff. Healthcare workers were really affected by the pandemic. They were the front-end staff and needed a lot of support. So the hospital did a lot of psychosocial counseling support for these people. And that was really helped the staff to be able to share their experiences and allay some of their concerns and fears. And that was really very encouraging, be part of it. Going forward, this is my last slide. Really, fighting COVID requires multiple approaches to be able to tackle it. You have to have prompt screening and diagnosis and appropriate mechanisms to provide care up to intensive care when needed. And that, as you can see from India, the experience is not very good. Ability to provide care is really challenged. So if you can't have appropriate care, then you really have challenges. Prof has touched on the vaccines. I wish not to go there. Vaccines are an important cog in COVID management. We're still struggling with getting enough vaccines, but we hope and we pray that very soon we'll be able to unlock that front and get more vaccines on board. So the countries must be continue to be really focused and decisive to be able to tackle the pandemic. I want to end by this quote from Poonam Singh, who is a regional director of WHO, who said that 3 priorities must chart the path ahead, where you must control and suppress the spread and strengthen and maintain the health services and support each other to stay safe and healthy during these very difficult moments. I wish to stop there. I don't think I want to stop there and take any questions or comments from the team. Thank you so much.
Thank you so much, Dr. Simon Onsongo, for this presentation. I'm sure all of us have now gained a wider perspective coming from the presentation by Professor De Wits, a microbiologist, and Dr. Onsongo, a doctor with a background in clinical pathology. So I'd like to still welcome questions and reactions, although I'm sure this being an introductory masterclass, still building the base for the whole masterclass, I'm sure the medical background may not be so familiar with those in the built environment, so we can still take it in.
Yes.
I can see there's a pertinent question from architect Shamla Fernandez talking about the AAK task force that was put together last year and the webinars that were held, plus the handbook that was published by the AAK, the COVID handbook. So I'd like to just welcome our Vice President Architect Florence Nyole to give us a few remarks and also maybe give a reaction to this question. Plus, if you have any other questions, we would like to hear from you. So feel free to either raise up your hand or type in the chat box. So Architect Florence Nyole, welcome.
All right, thank you so much, Brenda, and I hope you can hear me. And thank you very much for the presenters, Dr. Tobias R, I hope I've pronounced that correctly, and Dr. Simon Onsongo for such wonderful presentations regarding the COVID-19 pandemic. I think before I respond to Shamla, I'd just like to say that we're very grateful that Dr. Tobias was able to actually set the stage for us, so we're able to understand the virus, in its natural form and what exactly it is. Because coming from architects, we are experts in our work, but we're not experts in COVID-19. So thank you very much for setting that stage and giving us statistics on exactly where we are, and to imagine that the number of people who are actually infected or have ever been infected by COVID-19 could be 4 times that which is being reported, which is quite serious and very important for us to take note of. And thank you also, Dr. Simon, for letting us know some of the challenges that you're facing. And it's very encouraging to know that actually to this end, AAK did have a task force on COVID-19, and we produced a handbook that was covering about 5 areas. We're talking about immediate responses. We're talking about mobile hospitals. We were working with counties. We're looking at urban context, because we all know that public health is a major issue. And then to that end, as Architect Shamla has asked, is that we did produce a handbook. We shared it with the ministry. We had a webinar, and what happened is that as we shared that information, I think obviously there are probably very many other competing needs. I think the government was going through a tussle in terms of what you call budgetary allocations between national and county government. So some of the things that we had actually recommended could not be implemented at that point. But what I want to highlight is not so much those things that we've not highlighted, is that the handbook is still very relevant. We are very happy to kick it in. We are continuing to pursue those avenues, specifically through the Kenya Healthcare Federation, under which PharmAccess is also a major partner there, and we'll be continuing to do that. We've worked together with the Kenyatta University Hospital to do to help them with their infectious diseases unit, the IDO unit. We've also helped them to prepare in case this will escalate, as we have seen it before, to convert some of what they have as existing infrastructure into actually a quick hospital. We've also worked with Mutuini Hospital, which is under the Nairobi Metropolitan services. So that's part of the reason why we've been able to do that. What we have not yet been able to do is to help the government to quickly convert some areas to either have ICUs or places where they can actually host their oxygen tanks and be able to do that. But we have the manpower, we are ready to go. As Shamla has said, we already have these things in place. It's just a matter of being allowed to quickly put together a team and push forward the conversations that we've had there. But overall, I'm really excited about it. I think you've said it very well, that we need to support each other. Partnerships are very important. Now we are seeing ourselves as architects, engineers, professionals in the built environment having to cross over and work together with professionals in the healthcare industry. Who would have thought that this becomes the new partnership and alliance that you need to form? So we're very excited, and thank you very much to PharmAccess and PharmaHealth for enabling this, and to the two presenters and the entire chapter that has put this together. We're very excited to see this moving forward, and we're looking forward to having a great engagement during this masterclass. Thank you.
Thank you so much, Architect Florence, for that response. Seeing that there are no other questions for today's presentations, I'd like to welcome our rapporteur for the day, Diana Machoka, our Assistant Secretary to the Architects Chapter Council, to give us the summary for today's presentations. But before that, let me just highlight a question from Dr. Wafula Nalwa. He says, rather than heavy brick and mortar structures, do we have designs that can be used to put up more effective medical facilities? And I know this one is directed towards the association members. I'm sure it's the architects and surveyors, engineers, and construction managers who'll be able to answer this. Now, I'd like to postpone this question to tomorrow, since now we have two architects who will be doing their presentations, and they can take the Q&A from there. This would be a very relevant question to them. So allow me to once again invite Diana Machoka, Assistant Secretary to the Architects Chapter, to give us a summary for today's presentation. Welcome, Diana.
Thank you, Brenda, and thank you to the presenters for such an informative masterclass. I think we've all learned a lot. In summary, today, day one of the masterclass, we had the chairperson of the chapter council, George Arabu, and the president of AK, Wilson, just giving us an overview about what the masterclass will be about. And then we had Dorian Mulder of PharmAccess just introducing what PharmAccess is about and how better access to medical care will improve healthcare in Africa. And after that, we had a presentation from Tobias R, who was just taking us through what COVID-19 is. And he went through how epidemics come from human behavior and the acceleration in the 21st century, and where COVID-19 ranks in the top 10 pandemics in history. is at number 9, and how the other viruses have ranked in terms of number of deaths and the spread across the world. Then we had, he talked about what the virus means as a severe acute respiratory syndrome and how it mutates and the transmission routes through cross species and between human beings, and how it mutates, the global transition, talking about how the British mutation was a big deal, and how COVID-19 is unique in its pre-symptomatic transmission, how it transmits in the cells in the body, the transmission pathways, and how that informs social distancing, that we have taken into account the 1.5 meters in social distancing and the need for proper ventilation, giving us a good example of a restaurant of how the spread of the virus spreads in case of lack of proper ventilation. Some of the other things he highlighted were sewage water monitoring, the incubation period of the virus and the various stages of the virus, from infection to reactions to post-COVID syndrome, which are the symptoms after you recover. And then also he took us through the fatality rates in terms of age and even in terms of the global locations where we are. And also explained the concept of herd immunity and the development of the vaccine, how this was a record in developing the vaccine, efficacy, the clinical trials versus the real life effects. And also he explained why we are experiencing low fatality rates in Africa as well. Then we have Dr. Simon Onsongo, clinical pathologist from Aga Khan Hospital, Kisumu, who gave us an overview of the COVID situation specific to Kenya by giving us a context of the Kenyan healthcare system, talking about population and poverty levels and how that affects access to these facilities that we have. Then also he went through the organization of healthcare facilities in Kenya, going through the hard and soft healthcare elements. The hard healthcare elements being infrastructure and workforce, while the soft healthcare elements being issues of communication. Then he also took us through how healthcare facilities have prioritized patient-centered care and how COVID-19 has proved to be a stressor to the Kenyan healthcare facilities, given the poverty levels and the lack of access and the difference of the access for people in low-income areas as opposed to the other areas. And he also told us about how Kenya is now in the third wave of the COVID-19 virus and how Kenya is responding to this, the mechanisms, the partnership, the effective communication that the government has put in place, and also the common challenges of the COVID-19 affecting healthcare facilities, and how that is going to influence hospital design in the future, even though right now we have not adopted most of the things that should be taken into account for hospital design in healthcare facilities. Also told us about the Kenya's bed capacity, which is currently at 64,000, and also the percentage of access to oxygen supplies at 58% for these 64,000 beds, and also the availability of ICU needs in different counties. And then he also took us through the experience in the hospitals in Kenya, giving the example of Aga Khan Hospital in Kisumu, where he went through how the numbers of the COVID-19 patient bed capacity and the admissions, and how they have taken into account infection control, patients placement, and how it has affected reduced workflow due to the number of people coming into the hospital and people trying to avoid getting COVID-19 infection. So it reduced the number of people coming to the hospitals, and the staffing challenges in terms of the number of people who could attend to the COVID-19 patients, and even their psychological counseling, and the lessons that we can learn from this experience from hospitals is to adjust regularly, to be innovative, maintain effective communication, and improve partnerships between different stakeholders. And he also went through how we can fight COVID-19 going forward in hospitals. And then had responses from the participants that Brenda took us through, and architect Florence Nywele, our vice president, responded appropriately. Thank you. Thank you, Brenda.
Okay, thank you so much, Diana. We have come to the last bit of our class for today. Allow me to just give you a program overview for tomorrow. We do have two speakers from tomorrow. They are Marianas Dejaga, architect from A3 Architects in South Africa. He has over 25 years of being a director and has worked in the health sector in both private and public commissions. And then we also do have architect Caleb Mutali, who has worked extensively in healthcare facilities in Kenya, particularly the Aga Khan hospitals. And so tomorrow now we'll have the perspective from the built environment professionals who have experience in the healthcare sector. So allow me to give my thanks to today's presenters, Professor David and Dr. Onsongo. Thank you so much for the presentations for today. I'm sure we have all learned something, at least gotten a background that has introduced us to our masterclass. And I'd also like to thank the AAK leadership and the AAK Secretariat for hosting and facilitating this, in conjunction also with PharmAccess. Thank you so much to all the people who have come together to put together this masterclass. Thank you to all the participants who have joined. I can see we have over 82 participants at the moment, and I'm happy that you could all be here today, and I'd like to see you all tomorrow. So I can still see that there are comments coming in. We will be able to pick them up still tomorrow. So thank you so much to everyone who made this possible. I'd like to wish you a good day ahead and see you tomorrow. Thank you.
Thank you, bye.
Bye, everyone. Have a good day.
Thank you. Thanks, Brenda and everyone.